Hello, everyone. I'd like to issue a warm welcome to this symposium as part of CAHR 2021 Virtual. Thank you for joining us for this important session, Together We Can Stop the Virus, brought to you by Gilead Sciences Canada. I'm Dr. Chris Fraser from Victoria, BC, and we'll introduce a very good panel for you today. We have developed this panel together, the fellow panelists and I, Christian Hoy, Dr. Mona Lutfi, Dr. Benoit Trache. The views and recommendations expressed in the next hour during this program are those of us and us alone and have nothing to do with any positions or recommendations from Gilead Sciences. And we would refer you to the project monograph for each product mentioned in the discussion regarding indications, contraindications, and warning. We each have disclosures declared below for our work in education and research as indicated. In terms of this session, we think it very important to acknowledge the land upon which we all work. I am coming to you from the land of the Lekwungen-speaking people in the Songhees and Esquimalt nations, where I live, work, and build community. Dr. Mona Lutfi and Christian Hoy live and work in Toronto, the traditional territory of the Wendat, Anishinaabe, and the Haudenosaunee, and is covered by Treaty 13 with the Mississauga of the Credit First Nation. Dr. Benoit Trache lives and works in Montreal, the traditional territory of the Kanien'kehá:ka, on whose traditional territories he builds home, life, and community. So we have some important objectives today. We're going to identify social and clinical challenges of specific communities and vulnerable populations that hinder them from reaching the 90-90-90-90 goals. We are going to evaluate strategies being employed to address barriers and challenges to HIV prevention and treatment. And we're going to analyze strategies on how we can effectively work together toward our shared goal of ending HIV. Dr. Chris Fraser is me. I'm Medical Director of the Kool-Aid Community Health Centre in Victoria, BC, Clinical Faculty, University of British Columbia. Very pleased to be joined by Christian Hoy, MSW and PhD candidate, co-founder of Ontario Positive Asians, and also co-founder Canadian Positive People Network. Dr. Mona Lutfi, Professor Infectious Diseases and Clinical Researcher, Women's College Research Institute, University of Toronto, and Maple Leaf Medical Clinic. And Benoit Trache, Medical Director of Research at Quartier Latin, Montreal, and Clinical Associate Professor, University of Montreal. And we're going to lead off with an important conversation by one of the most pressing topics that's affronted all of us in the last year, the impact of COVID-19 pandemic on the cascade of care for people living with HIV. Christian, I'd like to start with you. From the community perspective, what changes have you observed in the cascade of care for people living with HIV since the start of the pandemic? And how do you think this pandemic has impacted particularly people living with HIV?
Thank you so much, Dr. Fraser, for the question. As you know, COVID has really impacted all of us, and in particular for people living in HIV, there are different considerations as well. So, and as related to the 90-90-90 cascade of care, in terms of testing, what I hear from, my peers of people living with HIV, they have expressed, some concerns about not being able to access STBBI testing for obvious reasons, over the pandemic due to lockdown restrictions. For key population groups, it depends, some of them may need to access safer consumption services. And, as we know, some of those essential services had to be reduced. So those are just a couple of examples of how the COVID has really impacted some of the, testing and clinical services. In terms of, treatment, I think most of us are quite happy that, we're able to get the 3-month supply of ARVs. I think initially that was a concern, but overall, I think most of us are able to get the 3-month supply. So that helps us really, take our medications, maintain viral suppression. In terms of retention in care, mental wellness has been a great issue. So, how are we going to address holistic health? So, as you know, social isolation has really greatly impacted many of us. And being able to address that, and also finding ways to take care of ourselves, in terms of our physical health, how are we going to be able to engage in virtual care visits. So some of those are considerations to think about. And then a couple of more feedback I've heard from my fellow peers is that COVID has really at times re-traumatized a lot of folks who actually went through the initial AIDS crisis. So are service providers able to engage and provision trauma-informed care? Some of the folks felt that with the heightened, public health kind of guidance and surveillance, they feel like they need to be vigilant in terms of not only how they engage with other people, but then in terms of them as sexual beings, how are they able to talk about, some of the concerns they have as related to sexual health needs.
Thank you very much. You touched on some really important content there that's very relevant to what we're approaching today. Mona, in your population, what's been the biggest challenge in caring for people living with HIV during the pandemic?
Thanks, Chris, for giving me an opportunity. I think Christian summarized it really well. I think first, the pandemic has been hard for everybody, but for people living with HIV, at the beginning, there was a lot of uncertainties. People living with HIV have suppressed immune systems, so we didn't know whether COVID-19 occurred more frequently and was more severe and led to more deaths amongst people living with HIV. So this was scary, I would say, for patients, and they were nervous, causing anxiety and stress and even depression. It's really great now that we have more studies answering this question. And the majority of the studies have actually shown that people living with HIV don't actually acquire COVID-19 more than people who do not have HIV. And then maybe 2/3 of the studies have shown that they don't get worse or more severe disease. And then 1/3 of the studies have shown that they do get potentially more severe disease. But all in all, I think very positive news that people living with HIV don't get worse COVID than people who don't have HIV. And then also COVID-19 has changed how we run our clinics and how we run our practices because many places have had lockdowns. We've had to go to virtual care. 90% of my clinic is done by phone now. Maybe 5% done by video and 5% in person. And this affects the care that we provide. Some patients like to be seen in person. Some patients coming to the office and seeing their care providers might be a very important social interaction that they get. And they're not getting that. At the beginning of the pandemic, there was a big question whether people living with HIV should get the COVID-19 vaccine at all. Initial guidance was that they shouldn't because they were excluded from most of the studies. And I'm happy to hear that jurisdictions have changed those guidelines, and this is posted on our clinic website, Maple Leaf Medical Clinic. Should people with HIV get the COVID-19 vaccine? And that's me, Dr. Mona, and the CDC say yes. And the Canadian recommendations have also changed, indicating that people living with HIV should get the COVID-19 vaccine.
Thank you so much, Mona. And yes, I completely support what you're saying there. And I've been gratified to see some of my older HIV positive patients getting access to the vaccine without incident, and indeed spreading through the whole cohort of unstable housed in my practice location here in Victoria. And hopefully many tuning in to this webinar have had the vaccine or soon can see their date coming up, and we can begin to pivot away from virtual care to more of our typical in-person care that we can provide. HIV caregivers have tried to approach care from a holistic perspective. One way to do that is to look at how we're doing with the 1990 targets. So let's now look at HIV diagnosis, the challenges and barriers we've faced in achieving this target. And I'd like to turn to Benoit at this point. Benoit, What coordinated efforts should HIV care providers in the community be doing to identify key populations who are HIV positive but do not know their status? What role does self-testing have in helping us to achieve the first 90 target?
Okay, well, thank you, Chris. That's an interesting question. I work in the gay village in downtown Montreal, so this is the main population we deserve in this area. So during the pandemic, we were able to see patients physically. That there are now 4 different sexual clinics in downtown Montreal. So we see a lot of patients, all of us together. So we screen, despite, like we did for COVID in the last year, we did also some HIV screening. So we test a lot of people. We also have some community group like Engage or Réseau that are screening on top of us for those who don't have any physician. So far, we don't have access to self-testing kits. But it's interesting that you asked this question because we will start soon a new research program with McGill University and Réseau, where we are supposed to test kits that are not approved in Canada yet, self-screen tests for HIV, HCV, and syphilis. So that should start in the next few weeks. And this is something that will eventually be available for the community.
And Christian, I'm very eager to hear from you from the community perspective. How can we improve our work in this pivotal step of HIV diagnosis?
Thank you, Dr. Fisher, and Maxi, Dr. Trottier, for your answer. So just first off, I think in order to address the 490s, I think it's very important that we actually all need to address the intersecting needs and also be able to address the impact of colonialism and the inequities that exist in Canadian society, such as committing to ending racial injustices. So in particular to testing, I was really glad that Dr. Trottier mentioned about the use of multiplex testing kits. And I think what I noted from his response is that McGill University is actually going to pair up with Réseau, which is a community-based organization. And I think in order for self-testing kits to be implemented effectively, that we must engage community-based organizations in a way because they actually really know how to implement these strategies and reach specific target communities. And then also, as a person living in HIV, I think one of the key priorities is utilizing peer-based approaches. So, while it's great that Canada has approved self-testing kits, we also know that a lot of the key population groups, their testing rates may be low due to a historical kind of considerations such as mistrust with governments, or the high stigma around HIV. So we know that peer-based approaches work, and how are we going to be able to implement peer testers and integrate them into these interventions?
Thank you very much. And I know, Mona, in your work, you've done a lot of excellent pioneering work with community groups. What would some of your thoughts on this important topic be?
Oh, thanks, Chris, for the opportunity to share my experience and thoughts about HIV diagnosis. Benoit, that's so interesting about what you say regarding HIV testing in the sexual health clinics in Montreal, because we've had a different experience in Toronto when the pandemic hit. Actually, sexual health clinics mostly closed down, and there wasn't a lot of testing in the last year. I don't know if you had that experience. And so I'm actually worried about decreased testing in the past year. So I'm interested to hear about your experience. I thought it might be interesting. I did share some more slides with you, Chris. I'm not sure if you could bring those up. Okay, thanks, Chris, for bringing up this slide. I thought a really good place to start with when we're talking about HIV diagnosis is to look at the HIV incidence rate across the country. And so what I put up here on the left side was the HIV incidence rates for 2019 across the country. They were just published on December 1st, 2020 by PHAC. And I thought it'd be interesting to compare it to the incidence rates across the country in 2018, which I've put on the right side of the slide. And I think one thing to note, and that's really great, is that the HIV incidence rate across Canada actually went down from 2018 to 2019. You can see that in 2018, the national incident rate was 6.9 per 100,000, and it went down to 5.6 per 100,000 in 2019. And looking what's happening at the different in the different provinces in terms of incidence rates can help us in terms of what are the different programs the provinces are doing in terms of diagnosis and testing. Where should we concentrate more efforts? And you can see in most provinces the incident rates are going down. Look at BC is as low as 3.5 per 100,000 in 2019. Ontario incident rates have gone down. Quebec incident rates have gone down. However, incident rates in Saskatchewan and Manitoba have not. So those are provinces where HIV testing should really special programs should be looked at. What's not working in those provinces. One thing to highlight is that in BC, an incredible province-wide programs called Stop HIV, where they put a lot of resources to outreach, to really go out into the community and do testing and diagnosis and start antiretroviral therapy right away. Such a program might be really good to roll out across the whole country. And also in a lot of these harder to reach areas, I think partnering with community, as Christian also mentioned, is really, really important in terms of HIV diagnosis.
Thanks very much, Mona. It's great to do a deeper dive into the data. And as someone from BC, thank you for highlighting the successful Stop HIV program here in BC. As we always say in BC, Canada needs more of BC when it comes to HIV medicine. It's a common saying out here. Thank you very much. Great conversation, everyone. Although it's important to know which key populations we're missing with HIV diagnosis, Linkage to Care plays a big role in our work to end HIV. And I know everyone on this panel is doing important work in that regard, as are people tuning in. And we're empowered by new excellent tools with ART that we can bring to our patients. Christian, I'd like to turn to you for some input at this point. From the community perspective, how can we improve linkage to care, and what strategies are needed that perhaps we're not using as much as we ought to?
Thanks, Dr. Fraser. While the global conversations are really shifting towards universal health coverage and wraparound services, I believe, in Canada, where we have a diverse community of people living in HIV, successful linkage to care really hinges on having differentiated approaches to meet the needs of specific populations. So it does not always mean a one-size-fits-all approach would work. And this will ensure that we don't leave any historically oppressed communities behind in the response. As you know, as a result of COVID, issues around health equity has really come as a forefront of something we need to address. I think something that would support, the linkage to care would be also expanded and improved access to pharmaceuticals as well. And then also in terms of, I've also mentioned earlier about peer-based approaches. And I think, in terms of being able to have peer navigators to support the community, we need to have well-compensated peer navigators who are securely employed. So they're able to actually do the work and build those relationships, as Dr. Luthi have mentioned. In terms of knowledge translation, it will be very helpful for scientists, researchers, to partner with community-based organizations or people living in HIV and members of key populations groups to determine how best we can actually generate knowledge uptake within key population groups.
Thank you very much, Christian. And turning to Mona, what strategies have you used in your places of work to improve linkage to care? And what additional efforts are required to ensure that social determinants of health are not barriers to accessing care?
Okay, thanks, Chris. And actually, Christian, you said a lot of the points that just came to my mind and that I was going to talk about. Chris, I think I sent you another slide. Maybe you can put that one up. I think that and many people know that the key population or one of the key populations that I work with are women living with HIV. And in my practice and in the work that I've done, providing holistic care and thinking about the whole person and what they need has been found to be essential. And at this point is probably not just important for women living with HIV. I think it's important for all people living with HIV. And so we developed actually a care model called the Women-Centered HIV Care Model. You can see that on the ground floor of this model, and Christian already mentioned this, providing trauma-informed care, and which we've termed trauma and violence-aware care, we think is essential when providing care for people living with HIV. And what does it mean to provide trauma and violence-aware care? Well, first of all, it's just knowing how high the rates of violence are amongst people living with HIV. In our studies, 80% of women living with HIV had experienced violence in adulthood, 80%. So we feel that all women living with HIV should be approached with the idea that they've experienced violence. And so to be empathetic and to listen is really important. You brought up social determinants of health. Well, that's the next floor, which is care that is person-centered and has attention to social determinants of health and family is really important. I'd have to say that ensuring that my patients have housing, have enough food, have enough money. Those are the basics that are really important to make sure people have before you even start talking about antiretroviral therapy and taking antiretroviral therapy. So we work, as Christian said, we work with the local aid service organizations to help with housing and access to food, but I can't stress enough how important those items are. And then on the top, we have peer support, and Christian also mentioned that. And we've seen some really amazing peer navigation and peer support programs that have really supported people living with HIV to access care and access antiretroviral therapy and access the information that they need, like Christian went over.
Thank you very much, Mona. I really love the graphic you've put in that slide, the idea of building home through HIV health and a greater awareness of the big needs of the populations we're working with. I think the only comment I would add is that we're really trying to reduce barriers to accessing care and trying to do some task shifting. So if it can be a peer worker, an outreach nurse, a pharmacy who begins that conversation and indeed begins the action cascade that leads to the starting of ART, we try to support that. And so if we can make it easier for people to start and continue their medications, I think we're moving everything ahead in a very good way. And we now have to move on to the next part of our conversation, which is moving towards the third 90, which is viral suppression of HIV. So we know that viral suppression of HIV leading to the shared goal of undetectable equals untransmissible and ending HIV is an important next step for HIV. Christian, turning to you at this point, what's the impact been of U equals U message in the community, and how can we amplify the messaging efforts to really ensure inclusion of other members of the community?
Yeah, thank you, Dr. Fisher, for asking this very important question, and something I'm really excited about. So for some of you who know me, you may know that I've actually been supporting this campaign from early onwards back in 2016, 2017. And for me and for many people living in HIV, the U equals U campaign has really empowered us to know the accurate knowledge about what viral suppression means, so that we know we cannot pass on HIV sexually if we are virally suppressed and if we are able to stay on treatment. So what this really means also is, unfortunately, for some of the communities that has experienced historically forms of oppressions and inequities, the uptake of the messaging has actually been a bit slower. So I think from my own experience, I know that it actually took a bit of time for these communities to really understand the messaging of U equals U. Initially, there were lots of questions, and I think some of the mistrusts actually were rooted in how some of these communities were historically negatively impacted by the scientific communities or the research communities. So being able to open up conversations that are culturally appropriate or culturally safe is very important. And I think just as I've mentioned many times already, being able to have peers, people who or the communities are able to relate to jumpstart these messages are very important as well. The last point I want to also make is in order to have effective U equals U messaging for key population communities, I think it's very important for researchers or service providers to co-develop campaigns and messaging because a lot of times people living with HIV or members of these key population groups, they know the best in terms of what kind of nuanced messaging is needed. So I encourage all to actually take a community-centered or community-led approach to creating those messaging.
Thank you so much. A lot of great ideas coming from Christian about how we can change the shape of our services. Benoit, what efforts do we need to implement to achieve this third 90 target, and how can we leverage U equals U to achieve this, in your view?
Yeah, well, Chris, this is my favorite 90. Why is that? Well, probably because this 90 goal was achieved more than 5 years ago. I would say even closer to 10 years old, 10 years ago in Montreal. And that is not only in the MSM population, but also in the IV drug users and the heterosexual contact. And why is that? Well, the main reason for that is that the second 90 was achieved many years ago also because patients are well taken care of by the community physician and the university hospital, but also because we now have regimens that are so good. They are not only good, they are well tolerated. They are less toxic with the years. And they come usually in one pill once a day, so they're simple to take. And they have a long half-life. So what does it mean for the population is that it means that even if you forget a pill once in a month or once in a week, it's nothing compared to what it was in the 90s and the beginning of 2000. If people used to forget their pill, they would develop failure with resistance, which is not the case anymore. So people are doing well. Almost every physician I'm following, not physician, sorry, but every patient I'm following has an undetectable viral load. And the consequence of that is U equals U. We saw the result 2 years ago in Amsterdam at the IAS meeting where they presented the Partner 2 study, and they showed that there was just no transmissibility of the virus when the viral load is undetectable. So I still remember the result that were presented there, and the celebration that we got after that in the a global village, they call it, where the community meet after conferences, and people were dancing, smiling with these results. And now it's disseminating in the general population. People are learning that they can now have safe sex without protection if they take their pill as it should be. So it's very exciting.
Thank you, Benoit. I love to see your typical energy and enthusiasm. Montreal is so lucky to have you there doing all your great work. And,
Thanks, Chris.
and it is truly, we've been blessed in HIV medicine to have these scientific data points which really change the paradigm of our work. And I would say the work I do in Victoria with people who use drugs, we've seen this as well, the fact that their life may be very challenging in terms of the multiple needs that Mona highlighted, but yet they can take their issue of HIV, become undetectable in 8 to 12 weeks, and this become a pivot to achieving other things in their life and being aware that they then cannot pass the virus on further along, even if it is still taking them some time to change their pattern of behavior with addiction. So thank you very much for comments there, Christian and Benoit. And we now get to move on to the fourth 90 target in this process, healthy living with HIV, which increasingly takes up a lot of our work in HIV medicine. Healthy living with HIV is an important target to achieve holistic care for our patient populations. And Christian, from the community perspective, from the lived experience, what does that fourth 90, healthy living with HIV, mean for people living with HIV? And what are AIDS service organizations currently doing to improve the quality of life for people living with HIV?
Thank you, Dr. Fraser, again for the question. So in terms of quality of life, I think, what's important is that, being able to address the holistic health is very important. So including the physical, mental, emotional, psychological, and for some, the spiritual as well. Quality of life means individuals should be empowered to have the ability to care for one's health. But as people living in HIV, we actually know that we belong, as diverse as we are, we belong to the same community. And we recognize that, if our fellow peers are falling off the cracks, we all suffer as well. So being able to address HIV holistically to improve the quality of life for the entire people living in the HIV community is very important. I think, just as people living in HIV are living longer, so being able to address the illness as an episodic, manageable disease, and utilizing various holistic rehabilitative approaches is, definitely important. For example, how can we actually support people living in HIV to pursue what they want and are interested in life? And do we have a system set up so that, we're not only implementing GPAP, but we're actually supporting people living with HIV to be able to maintain secured employment. Or, for someone like me, I'm going back to school. As COVID has kind of really raised the importance of social connection is very important. So how can we actually, engage folks? And I think a lot of AIDS service organizations have done this very well, over COVID, is to shift the services to virtual care. But yet also, I think we need to recognize that people may be feeling zoomed out as well. So I think the challenge is how can, service providers and also possibly clinicians to think about how can we engage people in this new normal and be able to enhance social connections.
Thank you so much. Again, you're raising such very important points for us to reflect on. And Mona, turning to you, what are HIV care teams currently doing to improve the quality of life for persons living with HIV? And what strategies do you feel are working? And how can we ensure their continued success?
Thanks, Chris. Benoit, I loved how you said the third 90 is your favorite 90. I would say this 90, the fourth 90 is my favorite 90. And, that's because, as you've all said, getting to undetectable is fairly easy now. We have very tolerable drugs, small single tablet regimens. And so people have undetectable viral loads. So the key is to have as high a quality of life as possible. And then while we have undetectable viral loads, we still have HIV stigma and discrimination. Why is that? I'd love to see undetectable equals no stigma. You know, that's, I would be dancing for that. How do we try to ensure that people living with HIV and our patients have as high quality of life as possible? Well, first of all, working in a multidisciplinary team, I think, is really important. I work with nurses, the AIDS service organization, social workers, the peers and peer navigators. I think that working as a team is essential to try to support quality of life.
Thank you, Mona. I think in our setting, it's represented by our motto at our health center is no wrong door into care, and the one-stop shop concept, where you try and deal with as many of those issues as possible with the same team, within the capacity of the same team. And that's where I think we feel like we've made some of our greatest headway. So if the person is most ready to deal with their substance use, most ready to deal with mental health, not so much HIV, you're able to support them until the other issues come into their stage of readiness to address it. So thank you very much. A really great conversation. And we're now going to move on to our one of our final topics, which is strategies for HIV prevention, where we feel we have many exciting tools that we can continue to work on and increase our efforts. We really think that in terms of moving forward, and part of the HIV care continuum, HIV prevention should be at the forefront of our efforts to end HIV. And Benoit, how can we increase awareness around HIV prevention and specifically PrEP amongst the medical community?
Well, Chris, this is a tough one, I would say. The thing is, HIV in the HIV treatment in the 90s and even in the 80s before that was considered a very specialized medicine. Only physicians were either trained as infectious disease specialists or HIV physician, whether like general practitioner, who had a special interest in treating HIV, were getting close to doing things around HIV, but most of the general practitioner were a bit afraid of even touching patients. So, and the reason for that is that you said, Mona, that for you that the fourth 90 was more interesting than the third one. I know it's easy now, but in the 90s and the 80s, they were just dying. And those who were treated in the 90s with the triple therapy at the beginning, yes, they were surviving, but they were developing resistance and drug toxicity. So it was tough here. So I don't know with PrEP, how we are going to be able to convince a general practitioner to give PrEP. What I see right now is patients who come from different regions around Montreal because their physicians are not comfortable giving PrEP. And for me, PrEP is so much easier than treating HIV 20 years ago. So I hope we will be able to convince at least the sexual clinics to offer PrEP to their population. So what can we use for that? Well, we have a symposium that we have in the province of Quebec that we teach HIV medicine and PrEP medicine in French. So I hope this way, by giving talks like that a few times a year, that we will be able to convince physicians to jump in and help us.
Well, I think with your energy and enthusiasm, Benoit, they'll be hard pressed to resist once we present it to them. Mona, how have you adapted your PrEP practice to accommodate for the virtual environment? It's certainly a challenging transition.
Well, so some of you might not know, but with some fellow infectious disease specialists, we started a PrEP clinic in Toronto, Maple Leaf PrEP clinic in 2018. And actually, just like, I completely agree with Benoit, just like he said, family physicians weren't providing PrEP. It's been around for over 10 years. The original IPREC study came out over 10 years ago. Why isn't it that PrEP use is widespread across Canada by gay and bisexual men who have sex with men who are at risk, and other populations? I don't understand that. And Benoit's right, family physicians aren't prescribing it. So in 2018, Dr. Phil El-Halou and Dr. Kevin Woodward and we decided we're starting our own PrEP clinic. And we have over 2,000 patients on PrEP. And we've gone virtual. And so I would say 80% of our visits now are done by phone. And this has helped. It's made it easier for patients to access PrEP. They can do the blood work on their own time. However, it's made some other aspects more challenging. It's more challenging to get swabs done for chlamydia, gonorrhea, or sometimes they'll have the visit, but then they don't go for the blood work. So there's good things about virtual PrEP and some other aspects that are more challenging. What can be done to increase access to PrEP? Well, in Ontario, we don't have universal coverage for PrEP, and this is a real barrier. I think provinces like BC and Alberta who have PrEP covered, and I think Quebec has PrEP covered. We don't have that in Ontario. I think that's essential for access. We tell people just to come to our clinic and we'll figure out how we'll get it covered. And special access programs are really important to allow that to happen. But I completely agree with Benoit. We need more people prescribing PrEP.
Thanks very much, Mona. And Christian, I'm sure you have some thoughts on how we can increase awareness around HIV prevention among those who would benefit most from its use.
I think just adding on to what Dr. Luffy and Dr. Trottier have said, I think, the key to HIV prevention is really, centered on an sexually educated community. So, just being able to start comprehensive sexual health education as early as possible, that embraces all sexual orientation, gender expression, one that's sex positive, utilizes non-stigmatizing language and harm reduction approaches is very key and essential, and that should start as early as possible. And I think from, just both Mona and Benoit's answers, it seems like we need more sex positive doctors. Come on, we really need that. So another, point is just having equitable access to testing and also access to PrEP, as Dr. Luffy have mentioned earlier. So, for some people in Canada, such as, international students, they may not have, their testing costs covered. And they may not always have, adequate kind of student health insurance. And if they get positive, they very often are not able to afford, antiretrovirals. So how can they do that? And, the same goes for PrEP as well. For certain provinces where there's, limited coverage, unless if you're on certain plans, you might not be able to, access PrEP. So those are very important key structural issues that we need to think about. And just last and not least, because I'm a person living in HIV, and we actually should always include people living in HIV when we talk about prevention efforts, especially we know about U equals U. So a good campaign is the Positive Effect website. So on this website you can see a lot of testimonials from people living in HIV, but it also has sections on testing, prevention, positive prevention, U equals U, how to live well and healthy life. So I would recommend folks to check out some of those sites.
Thank you very much. And hopefully when we have this symposium in a year or so and moving forward, we can all report back that we've seen an expansion of PrEP access and services in all of our respective communities. Thank you very much. I've really enjoyed this conversation. We've discussed many barriers and challenges relating to HIV prevention, treatment, improving overall quality of life of people living with HIV. We've also discussed strategies that have been implemented to address these challenges. And now, as we close off this symposium, we wanted to discuss innovative solutions that have come forth in HIV care during COVID or otherwise, and whether these solutions should continue beyond the pandemic to provide people living with HIV alternative ways to access care. And Benoit, what innovative solutions have been implemented in your work as a result of the pandemic that have been positive additions to caring for people living with HIV?
Well, Chris, you know what? We learned that during this pandemic, as all the other cities in Canada, we learned that we could do a lot just by seeing a virtual patient over the phone or on a computer. We don't use computers, but we just do phone visits. Because it's too complicated with the videos, but it works well, and we just realized that patients like it also because they don't have to take a day off from work. They don't have to disclose their disease and say, well, I have to leave, I have to see my physician, and people asking why not, all of that. So we do a lot of virtual medicine right now, and we do it for PrEP also. For some, like 1 out of 2 visits is done virtually, the other one is done in person. So as Mona mentioned, we screen a little bit less for other STIs, but we still do some, and we find things surprisingly. So I just hope that there will be a way to continue that, because normally in the province of Quebec, we're not supposed to see a patient in a phone call. It has to be an in-person visit. So I just hope we continue that after the pandemic.
Thank you very much. And Christian, from your perspective, what innovative solutions have you seen implemented as a result of the pandemic that have been perhaps positive additions to the care received by the HIV community?
Yeah, so thanks for the question again. And, I think just to reiterate, as we had seen from COVID, what really was brought to the forefront was a focus that we need to focus on health equity and also like the holistic approach to care. There's been some innovations in terms of harm reduction supports too. So for example, people who use drugs, they actually, provide virtual peer witnessing, support for those who may be using. And this is very important amidst the opioid crisis. And also while, the safe supply interventions, did not come out from COVID, it was something that was adopted during, this time frame. So I think just being able to think innovatively on how we can provide harm reduction support to people who use drugs is very important. And also, last but not least, thank you for all the frontline workers, medical doctors and allied health care workers to support people living in HIV and members of key population groups during the pandemic.
Thank you, Christian. What a wonderful statement to wrap up our conversation on. You covered it off extremely well. A great appreciation for innovation and a great understanding that community has so many strengths that we can draw upon. Indeed, I think as clinicians, we need to really turn our gaze in that direction more often so we can learn and stay connected to innovations that are happening in our communities amongst the populations we're working with. And I really am appreciative for all of the panelists for their comprehensive inputs across this wide range of conversation across the 490 goals with HIV, and then understanding and thinking about how COVID has played a role in that, hopefully less so in the next year as vaccinations disseminate much more broadly to all aspects of Canada, indeed all our population. And so thank you very much for that. And I know now that we're going to have some time to be able to respond to some live question and answers, and we'll look forward to people submitting their questions so we can have further discussion. Thank you very much.